This presentation will discuss the challenges of addressing comorbid disorders, the results of research to date, and gaps in knowledge. Dr. Hodgins will review the results of a scoping literature review of mental health and substance disorder comorbidity in gambling problems. Although it is clear that such comorbid problems impact the development and recovery from gambling problems, practical solutions have not yet been devised and implemented. David C. Hodgins, Ph.D., is a professor in the program in clinical psychology in the Department of Psychology, University of Calgary, and a coordinator with the Alberta Gaming Research Institute. He is registered as a clinical psychologist in Alberta. His research interests focus on various aspects of addictive behaviors, including relapse and recovery from substance abuse and gambling disorders. This video has been professionally narrated from a presentation given by David Hodgins on October 5th, 2016. Today I'm going to talk a little bit about comorbidity issues. Comorbidities indicate the presence of a mental health or substance abuse disorder, either concurrently with a gambling problem or sequentially with a gambling problem. It's important to conceptualize comorbidity broadly. Sometimes the term dual diagnosis is used in the literature. However, the term is most often used to refer to developmental disability and comorbidity, so we don't tend to use dual diagnosis in this field. A more important issue is the idea of multiple comorbidity. This is in recognition of the fact that people who have one comorbidity with gambling will often have more than one. When reviewing the literature, you get a very different perspective if you're looking at community samples versus treatment samples. They're both important perspectives, but when you're studying people in treatment samples, they are a very select subgroup of problem gamblers. This is important to keep in mind as we look at the literature. So what did we find with this comorbidity review? Our first search of a few electronic databases found 14,000 articles, and then we found another couple hundred through other sources. When we removed duplicates, there are 8,500 articles. When we read the abstracts, we screened out 8,000 of them, which left more than 500 articles to read. We excluded 142, so our final synthesis has 379 articles. The vast majority of the studies are focused on prevalence. We also have some systematic reviews. These are very specific types of literature reviews that analyze across studies and draw statistical conclusions. There's one here from 2011, and it captures what we know about comorbidity in community samples of problem gamblers. Essentially, it's very common. In this main analysis done in Australia, they found 11 studies. They found that there was a lot of variability from study to study. Among community samples of people with gambling problems, approximately 60% have any substance abuse problem. Most of this is smoking. Alcohol problems affect about 1/3 of people, and illicit drugs 17%. Mood disorders like depression and bipolar disorder affect about 38%. Anxiety is about the same at 37%, and antisocial personality disorder affects 30%. This is a summary of one of these recent studies included in that meta-analysis. First, it speaks to the idea of multiple comorbidity. 3.7% of people with problem gambling have a gambling disorder only. That means that 96% of people have at least one other disorder. 64% of people with a gambling disorder have 3 or more mental disorders. This study was funded by the National Center for Responsible Gambling, and it illustrates multiple comorbidity. Now let's talk about treatment samples. This meta-analysis uncovered 36 studies that looked at treatment samples with gambling problems and assessed comorbidity. Any substance use, 58% of people. Alcohol, 21%. Illicit drugs, 7%. Nicotine, 56%. Any mood disorder, 23%. Any anxiety disorder, 18%. ADHD, 9%. And finally, 75% is the overall rate of comorbidity of problem gambling with any of these clinical disorders. You can see that the disorders are similar, but what was surprising is that you would expect higher rates of disorders within treatment samples than in community samples. However, rates aren't consistently higher in treatment samples than the community samples. We might expect rates to be higher in treatment samples because any of these other disorders might drive people to seek treatment. However, this doesn't seem to be true. So then the next question is, does it matter? There are lots of studies that draw a clinical picture that say that it does matter, that people with comorbid disorders have more severe problems and more severe gambling problems, and they have more severe psychosocial problems. They have more family dysfunction, and they have greater levels of impulsivity. The assumption that we make is that their clinical pathway or course of the disorder is going to be rockier. They can be more likely to drop out of their treatment. They're going to have more treatment outcomes, poorer gambling treatment outcomes, if they participate in treatment. So that's the next question that we looked at. I'm going to quickly talk about one clinical case to give you a flavor of what we would typically see. This is a guy that I saw, a 25-year-old guy who was self-employed in the oil industry, selling drilling equipment. It was a very lucrative profession for him. His father had set him up in his job after high school, and he made really good money with it. The position didn't really take his full time, but he could work and create some wealth, so he began to gamble on the internet and develop significant debts quickly. When you talked to him, you saw mainly a phase of life problem. He felt anxious and depressed. He didn't really know what he was doing with his life. All of his friends had gone to university, they were graduating and were starting their careers. He hadn't gone to university because he had such a good opportunity. He felt like he didn't really know what he was doing. He very clearly had an alcohol problem and maybe a diagnosable depression. He was an escape gambler. He liked to get online and play poker because he drifted away. He didn't have to worry about his life and think about his problems. A cognitive error that we would focus on in therapy was that he saw gambling as a solution to his financial problems, even though he knew that it was causing him more problems. I saw him for a few sessions, and he did well. We did cognitive behavioral work. He quit gambling and seemed pretty stable in quitting gambling. He really wasn't willing to address his drinking. I would gently talk about it occasionally, and he just wasn't going there. So he continued to drink heavily, which didn't seem to be linked to his gambling situation. Is it just coincidence that he has both? Or is there some sort of vulnerability that created a gambling problem with the alcohol problem? It wasn't clear, and I wasn't in a position to do longer-term follow-up, so I don't know what happened. That's often the situation. The agreement is that there's something else there, but if there's any problem gambling, you try to address it, and then you're not quite sure what to make of the other issue. So let's go back to the data. Does it make a difference, this comorbidity? A little sidebar is that overall treatment is pretty effective, and we have a growing body of randomized clinical trials and other types of evaluations that are pretty suggestive that treatment is helpful. What was really clear is if you look at all of the literature, in very little of it do they report the impact of comorbidity and outcomes, so that even though we've known for a long time that these are big deals, we assume that it makes a difference. But if you actually look at the randomized clinical trials, very few of them report on the levels of comorbidity and whether that impacted the outcomes. So the first recommendation arising from this review would be that treatment outcome research incorporates this measurement into the designs so that we can collect more information. However, there's enough data that suggests it does not make a difference. Again, our Australian friends have done a systematic review where they identified 21 studies that look at one or more comorbid disorders, and the results here are quite surprising. There were 12 studies that looked at the effect of mood disorders on gambling treatment outcomes, and of those 12, only 2 of them showed a negative effect. For alcohol abuse disorder, of 11 studies, only 3 showed a negative impact on gambling treatment outcomes. For anxiety, of 12 studies, only 1 showed a negative impact. For personality disorders, there was 1 study and there was no effect. So how do you interpret that? This is a very meager database, so you don't want to conclude that it doesn't make a difference. One of the plausible interpretations is that people might make sensible decisions about where to present for treatment. So people who are choosing to come for gambling treatment are doing it because their other disorders are under control, or they're handling them reasonably well. It could be a selection factor, so that the person with comorbid depression and gambling who is really suffering from the depression is going to go to the mood disorder clinic or going to go to the family doctor and get antidepressants, and is not going to choose to go to a specialty treatment gambling program. So we need to study the impact of the gambling disorder on mental health and substance abuse treatment and gambling. We know that gambling disorder rates are higher in these patient groups. Here's another meta-analysis, again from Australia, with 25 studies of substance abuse treatment, where they assessed the problem gambling. The overall rates of disorder were 14%, and then a broader category of problem gambling was 23%. There's really no literature on the impact of a comorbid gambling problem on treatment outcomes when the client is being treated for substance abuse or for mood disorders or for whatever they're being treated for. This is a real gap in the literature. Clinicians and researchers tend to overlook issues that are not a focus of their treatment programs. It's hard to convince physicians to screen for gambling problems. You might convince them to do it, but actually have them do it routinely is hard. But I think that's true everywhere. For example, screening of mood disorders. Education is important, but we need to also build in routine screening so we don't rely on clinicians to remember to do this. We know this from all sorts of areas of healthcare, that acute performance is what leads to consistent performance. So having some screening scales that are broad-based are important. The other thing that we need to do is to assess the efficacy and effectiveness of doing brief interventions in these contexts. We assume that they work, and we know that from the alcohol field, if we can get to nurses to do a mini intervention at the bedside, that actually has an effect. We don't really know that for gambling, but can we understand that process better? But we understand the patterns of co-occurrence better, so we know where to put resources. So I don't know if my urologist should be asking me about gambling when I go to the urologist, but if I go for treatment of depression, it should be asked of me, because we know that the base rates are relatively high within that group. We have to have a better understanding of how these things co-occur to know where to put the resources. So here's an example of the kind of research we can do to determine where gambling problems will show up in numbers large enough that we should be doing screening, as opposed to doing screening everywhere. This is a study that we did in Alberta looking at a broader range of behavioral addictions. We did a telephone-based survey, along with my panel survey, of general population, where we asked people pretty simple questions about whether they experienced an alcohol problem, tobacco, marijuana, cocaine, gambling, shopping, video gaming, eating, sex, or work, whether they experienced that in the last year. That's what the red line is. It's the prevalence of that problem within the general population. You can see that for alcohol, it's about 5%, and even though it was a very simplistic assessment we were doing, that lined up really well with what we would have expected from a more sophisticated prevalence survey. Smoking was at 20%, and we know that in Alberta the rate of smoking is in the general population at about 19%. So this pretty simple way of assessing it seemed to produce a pretty reasonable prevalence rate. Gambling's here, it's 3% in the sample, which is not a bad estimate. You can see that some things like eating were higher, work is surprisingly high, and so forth. We also asked people what they perceived the prevalence of each of these behavioral addictions to be, and the blue line shows that pattern, which is what we expected from previous surveys, that the general public always overestimates the number of people with problems. That's true for gambling as well as other disorders. So then the issue is that you have these rates of prevalence, but how can you understand how they pattern together? What are the patterns of co-occurrence? We did a cluster analysis to pull out different groups of types of people. In this sample, half of them didn't have a problem. In the other half, 30% of them had one, and 21% had two or more. So we did the analysis on a group of people who had one or more disorders, and we found that there were 7 different groupings of people. The first 3 are relatively pure disorders. That is, they report only one disorder. There's a group of people that reported they had a problem with smoking and didn't report other problems. There was a group of people who identified excessive eating as a problem and didn't identify other problems, and a peer group of workaholics. And then there was a group of people who identified shopping as a problem, and they tended to have 1 or 2 additional problems. This tended to be more women than men. Eating and smoking were the 2 other disorders that grouped particularly frequently. A group primarily of men who identified sex also had 1 or 2 additional comorbidities. A group of video gamers tended to have 1 additional comorbidity, and then we had a group of mixed addicts. These are people that, on average, reported 2 or 3 different comorbidities. This is where all of the gambling people showed up. So they didn't come out as a separate group, they came out as a group that had a number of other things going on for them. On average, for people with gambling problems, they had 3.4 problems. Gambling, then 2.4 additional problems. So the question is, are there hypotheses about how these behavioral and substance abuse problems go together in different ways? We should expect this to have implications for how we would think about treatment and where we should put our efforts in terms of screening. I'm not suggesting that this one study from Alberta should lead to changing our treatment systems, but it's a way of thinking about it and an approach that we might want to take. Thank you. Any questions?
That's really impactful, and thank you. This presentation really resonates with my experience in a tertiary care setting. We're having more complex clients, more chronic and acute. If I was presenting on this, I would be saying something like what you're saying, except in Canada, it's 5.2 comorbidities. So all of that is to say that tertiary care focus still needs to be there because people are coming in having a whole bunch of serious problems, but places are missing them.
Yes, remember that our sample is a community setting. We did ask them questions about whether they have treatment for these disorders, and, of course, treatment rates were really low. They were low for disorders where there is no treatment, for like video game addiction, but low also for alcohol and low for everything as well.
So thinking about how to get the high at-risk groups who are not yet seeking some sort of treatment, how do we reach them? What's going to resonate with this group? This ties into what I'm doing. I'm wondering, how do you prevent those people from falling off the cliff?
Part of the answer is knowing what kinds of struggles people have, and I think the purpose of this project is to actually develop a very brief behavioral addiction screening tool for use in the general population. It's not a clinical tool, it's a general population survey tool, and so I think having the ability to identify and measure some of these issues is helpful. I think moving beyond our traditional mental health surveys that assess DSM-defined disorders, it is perhaps more helpful to subscribe to an addiction syndrome model that says that addictions are going to show up and express themselves in various ways. I think that might be part of it. It's actually knowing where they are and identifying them is the first step. The other part of my answer is, from my observations in the brief intervention and secondary intervention work in the gambling field, most of the change that occurs long before people label themselves as having a problem. So I think helping people focus on the consequences that they have or worry about having that are related to a behavior or a disorder, a symptom, is a more fruitful way of engaging people to make changes. We have our screening tools where we try to have our general population identifying themselves as problem gamblers. I don't think that's necessarily helpful, because lots of people who are going to meet the screening for problem gambling are very far from self-labeling themselves. Let's focus on the consequences as opposed to the label. That's as good as I can do right now.
I just have a very brief comment on patterning of comorbidity and the need to measure differently. I'm involved in a systematic review of treatment as prevention in youth, assessing whether treating one mental or addiction issue prevents the onset of others. We think this is true for the youth. The problem with extracting data is that study designs do not measure enough outside the intervention or afterwards to be able to see if you're preventing other problems. Researchers don't want too many measurements in the follow-up period, but that's actually where you can see if it's preventing other problems. We're challenged by this with the literature. I think having researchers systematically measuring to get at those secondary prevention pieces would be great.
Yes, one of my graduate students is doing a systemic review right now from the addiction substitution perspective. So it's really the same issue from the opposite vantage point. When people give up an addiction, are they vulnerable to developing another one? It's very hard literature to find.
Can I just add to that? Because I guess my question encompasses looking at the life course trajectory in this comorbidity issue and then perhaps getting treatment. My question is going to longitudinal studies, where there has been treatments such as CBT and MI to treat anxiety and depression, as well as for problem gambling. Have there been any longitudinal studies where participants have received, for example, CBT, and then if there are waves of different outcomes on other disorders?
I would say almost none. That's the question of what happens over the course of treatment, and there's a hint in the literature that this is happening. The hypothesis is that people who have recovered from a substance addiction are protected from subsequent substance addictions, but not necessarily protected from subsequent behavioral addictions because they do not perceive these disorders in the same lens. They don't have the cautious approach. So in the early days, less so now, but when we first started to do research on gambling problems, about 40% of people from the community had a history of alcohol problems that had resolved itself. That's not true anymore. There's been a shift now that I think people have an awareness of gambling as potentially addictive, and that wasn't true in the 90s when it was first introduced. So then increasing awareness is, I think, important in a protective sense. People are potentially protected from subsequent disorders, but that's a hypothesis.
Griot has a review that discusses the literature around intergenerational issues. One section of the review addresses this need for broad screening. One of the things that's gaining momentum around the country has been the promotion of GAIN-SS. Global Appraisal of Individual Needs is a short screener for general populations to identify people who have one or more behavioral disorders and would benefit from further assessment or referral for these issues. It also rules out those who would not be identified as having behavioral health disorders. In fact, the folks in Ontario actually got gambling added as a question. It's a quick 20-question broad screener that you give to people. What do you think about the use of a tool like that, especially given that you're describing a comorbid population?
Yes, and that's the only way that we're going to be able to get any kind of systemic identification of individuals through some sort of organized screening. You know, it does pose the dilemma if you screen and you identify a problem, what do you do about that? But I think human nature being what it is, we need that kind of structure to do that job.
So that requires building some tools for people who are actually working with the instrument so when they get a positive gambling result, there's a step 2 for them.
Yes, that's right.